Hey guys, welcome back to my channel, The ENT Resident. Today I'll be continuing my series on tracheostomy, and today is part 3 where I discuss about the complications of tracheostomy. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. Now, complications of tracheostomy can be classified into three types. First is the immediate complications, which you see right at the time of operations. Second is the intermediate complications, which can be seen within the few hours to days of the surgery. And last is the late or the delayed complications, which is usually seen in long term tracheostomy users. Maybe it develops within weeks to even months of the surgery. We'll discuss each one of them one by one, all the different complications under them, and we'll also discuss how to manage these complications. So, starting with the immediate complications, our first complication, which is usually the most common complication in any surgery, is hemorrhage or bleeding. Now, this is also the commonest fatal complication. There are various causes to this, but the most common ones would be injury to anterior jugular veins, anterior communicating veins, and injury to the thyroid isthmus or the thyroid gland. These are the more common causes. The anterior jugular veins are usually found right on the either side of the midline in while you are doing the first few steps of tracheostomy. I have mentioned this while when I discussed all the steps of tracheostomy. Other than this, we have the inferior thyroid vein also, which can be injured. And if there is any other anomalous vessel, like the thyroidea emma artery or the innominate artery, these can also get injured. These are the various causes why we may encounter bleeding during the time of during the time of tracheostomy. Now, how do we prevent this? Our prevention would be, first of all, we stick to midline dissection. We should be aware of the anatomy of the patient. Second, when we come across the thyroid isthmus, we should either retract the isthmus or divide and ligate it, but we should avoid any transection of the thyroid isthmus. And if after taking every preventative measure, even then, if we end up with bleeding, in that case, we have to explore the wound and find out which is the bleeding vessel. And once we locate the bleeding vessel, we have to ligate it. So that's about our first complication, which is the most common complication, which is hemorrhage. Second immediate complication could be a air embolism. Now, this is usually a very rare complication, but if it does occur, it is very life threatening. Now, why will this occur? Now, during the time of surgery, if any large vein of the neck gets opened up, then air can easily get sucked into the venous system and pass right into the right atrium, and that will lead to air embolism. Usually, we try to manage it conservatively and put the patient in a head low position. That's how we manage air embolism. Next complication is damage to local structures. Now, there's a lot of structures that are around while we are doing tracheostomy, and a lot of them can get damaged. Now, what are all these structures? First of all, is carotid artery. Now, if the carotid artery in the carotid sheath gets damaged, this will usually happen if you dissect more laterally. This can lead to catastrophic bleeding, which can be very, very difficult to control. Second is the esophagus can get damaged, which lies posterior to the trachea. Now, if esophagus gets damaged, it can lead to the development of a tracheoesophageal fistula, where basically, if this is the trachea and this is the esophagus, a communication develops between the posterior wall of trachea and the anterior wall of esophagus. This leads to a fistula formation. Now, if this fistula is very small, we can do conservative management with nasogastric tube, but if it is a large one, this will require surgical closure. We have to suture both the trachea as well as the esophagus separately and with an interposition of soft tissue in between them. So that's about damage to the esophagus leading to tracheoesophageal fistula. Third, we can end up damaging the recurrent laryngeal nerve, and if this nerve gets damaged, it can lead to hoarseness of the voice and respiratory distress, depending whether both the nerves are damaged or not. Fourth is we can also end up damaging the apical pleura. If that happens, it can lead to the development of pneumothorax. Now, depending on the type of pneumothorax, our management will vary. If this is a very small pneumothorax, usually it can get resolved on its own, or sometimes just suturing of the pleural tear is enough. If the pneumothorax is large, then we manage it with oxygen, antibiotics, and placement of an intercostal drain. But if this pneumothorax is a tension pneumothorax, in that case, we have to aspirate the upper anterior thorax with a 14 to 16 gauge needle. So these four structures, the carotid artery, esophagus, recurrent laryngeal nerve, and the apical pleura, these are all structures which are more prone to damage if we end up going too laterally while performing dissection during tracheostomy. Other than this, some other structures that may get damaged is the tracheal walls and the cricoid cartilage. Now, if the cricoid cartilage gets damaged, we have spoken about this in my last video where I discussed that it can lead to the development of subglottic stenosis. This is the reason why we usually avoid performing a high tracheostomy, which is usually done through the first tracheal ring. Now, because the first tracheal ring lies in very close approximation to the cricoid cartilage, it poses a risk to forming subglottic stenosis. In these cases, the tracheostomy should be resited lower in the trachea and we should repair the damage. Now, both tracheal walls and the cricoid cartilage, they can get damaged because of inadequate incision or poor retraction or even poor hemostasis, leading to less than ideal exposure. Our next complication is apnea. Now, why will apnea occur if we are placing a tracheostomy tube just to deal with the problem of hypoxia? Now, what happens is in a patient who has been in a chronic respiratory obstruction for a long period of time, in them hypercapnia, which is increased CO2 levels, and hypoxia, which is decreased oxygen levels, both of them together, they act as the respiratory stimulus. This only happens if there is a chronic respiratory obstruction. Now, moment you do tracheostomy, the carbon dioxide level falls and the oxygen level increases, as a result of which the central respiratory drive is lost in this patient because the hypercapnia and hypoxia, which was acting as the respiratory stimulus, has suddenly disappeared. How do we manage these patients? We manage them by administering them carbogen. Now, what is carbogen? Carbogen is 5% carbon dioxide in oxygen. Or we can even give assisted ventilation to the patient. Next is the patient can have aspiration of blood and secretions during the time of surgery. Even a development of false passage may occur. What is a false passage? It is when you think you are putting in the tracheostomy tube into the trachea, but sometimes you can end up going laterally and develop a false passage. You may think that this is the trachea, but it is actually not the trachea. A false passage has been created. In these patients, they'll present to you with features of respiratory obstruction. Now, the early features would be a fall in saturation, and other than this, we'll see tachypnea, we'll see tachycardia. But if this is going on for a prolonged time, we'll see late features would be development of cyanosis and eventually bradycardia formation. So, this is what we'll see if there is respiratory obstruction in a case of false passage. Lastly, the last immediate complication is cardiac failure of the patient. This can happen due to three reasons. One is because of the fast rise in the pH. Second is if there is an increase in the adrenaline. And third is if there is hyperkalemia, which means increase in the potassium levels. We know that increased potassium levels leads to arrhythmia and eventually cardiac failure of the patient. So these are all the immediate complications of tracheostomy which will be seen during the time of operation. Now let's move on to discuss the intermediate complications. These are the complications which develop during either the first few hours to within days of the surgery. Now, our first most important one is if there is an accidental extubation or displacement of the tube. So sometimes what happens is the tube may get displaced into the pretracheal space. That means lie in front of the trachea. And this complication may not be immediately apparent. So sometimes these patients will continue to breathe, but as the soft tissue keeps gradually prolapsing around the tracheal opening, and then it starts sealing this opening. Slowly, the dyspnea will increase, and by the time the dyspnea becomes apparent to you, the tube may be very difficult to replace as the tracheostomy has virtually closed. Now, what are some factors that lead to displacement of the tube? One is if you have placed the tube incorrectly, like placing it in in a false passage. Second is if the tapes that you tie around the neck to secure the tube are loose. So if the tapes open up for some reason, it can also lead to displacement of the tube. Third is if the patient has excessive coughing. And lastly, if the patient has agitated movements, in especially in uncooperative patients. All of these factors can end up leading to displacement of the tube accidentally. When should you suspect this? We'll suspect this when the patient is suddenly unable to speak, the airway becomes obstructed, and we are not able to pass the suction. So, when we discover that the patient has displacement of the tube, we have to deal with the cause that might have led to it, and we'll have to put the tube back. Now, how do we prevent this case? This can be prevented if we securely adjust the tube properly during the time of the procedure, and we suture the tube around the flanges of the tube to the skin. That will make sure that the tube does not get dislodged at all. So that's about displacement of tube, which is actually a quite a common complication, but very easily treatable complication. Next is blockage of tube. Now, the tube may get obstructed because of various reasons. There may be crust formation occurring, or there may be granulation tissue, or even because of poor placement of the tube with respect to the tracheal wall. How do we prevent this? By regularly performing suction and by periodic tube change. Now, the suction, how do we suction this? I have spoken about this in my last class when I discussed the post-operative care of the patient. I have discussed in details how should we perform suctioning in a post-tracheostomy case. Next complication is subcutaneous emphysema. Now, how does this develop? So, if a tracheostomy tube or the trachea gets obstructed and we have given very tight skin incision closure, in that case, the air may be forced out into the soft tissues of the neck during the time of expiration, and slowly it leads to the development of subcutaneous emphysema. And this subcutaneous emphysema can even track as high as the lower eyelids or as low as the upper chest, even, and in very severe cases it can end up in causing displacement of the tube. So when you examine the patient, you will be getting this feeling of crepitus when you are palpating the surrounding area. Now, what are the primary causes of developing subcutaneous emphysema? It could be because of cough. Second, if we do not use a cuffed tube, if we have used an uncuffed tracheostomy tube, if we have given very tight skin incision and close them very tightly. Fourth is if the pretracheal layer has not been opened properly. In my last class, I was talking about before you incise the trachea, you have to make sure that you have made dissected of the pretracheal fascia properly. If it is not opened properly, it may lead the air leak may go into this layer and lead to the development of subcutaneous emphysema. Now, how do we treat these cases? Usually, we by removing the tight skin sutures, it resolves by itself. But even after doing that, if within the next 24 hours it does not resolve, we replace it with a bigger tracheostomy tube. And it is important that we use a cuff tube over here to prevent this from happening. And even after it happens, we should replace the uncuffed tube with a cuff tube. And even if then it does not get resolved, we can place multiple incisions over the affected area. That will lead to the release of the air which has accumulated. Moving on to our next complication, which is tracheoesophageal fistula. So, this is basically a communication between the trachea and the esophagus. So, I already spoke just a little while back about this. Now, how can this happen? What would be the cause behind this? This can happen if there is a damage during the time of surgery to the posterior wall of the trachea, or if there is a constant rubbing of the tip of the tracheostomy tube on the posterior wall of the trachea in the early post operative period. In this case, it can lead to the development of this fistula between the posterior wall of the trachea and the anterior wall of the esophagus. Now, when do we suspect this? There are certain conditions like if we are seeing that there is progressive difficulty in ventilating the patient, if the constant increase in cuff volume and pressure is required to maintain adequate PEEP, so, if the need constantly increases, if we see that there is air escaping into the hypopharynx, or if the patient is recurrently aspirating or is developing recurrent pneumonia, in all of these cases, we should suspect the development of a fistula in between the trachea and the esophagus. The only way to treat this is to first perform an endoscopic examination and perform surgical closure of the fistula. Next is another fistula, which is a tracheoarterial fistula. Now, tracheoarterial fistula is most commonly seen in a patient who has been previously irradiated, particularly if a low tracheostomy has been done in these cases. Rarely any premonitory sign is seen, and the usual presentation in this case is when the patient comes with sudden massive hemorrhage. Important MCQ question over here is the most common artery affected in tracheoarterial fistula in a tracheostomy patient is the innominate artery. How do we treat this? We'll have to change the tube immediately for a cuff tube and then inflate the cuff to prevent further aspiration. Second, we apply compression to the bleeding vessels. And lastly, we explore the wound and close the fistula. So, that is about our tracheoarterial fistula. Some other complications which happens in the intermediate period are there can be an inflammation of the trachea leading to tracheitis and tracheobronchitis with crust formation in the trachea. There can be local wound infection and stomal cellulitis. In this, this can be prevented or rather even treated with regular change of dressing, and we also need to treat the infection with antibiotics. Next complication is atelectasis. Now, partial atelectasis can happen because of aspiration of blood and secretions. This will require conservative management, and total atelectasis will happen due to improper placement of tube into one bronchus, leading to the collapse. In these cases, we can just readjust the tube, or even sometimes shorter tube may be required. Then we come to hemorrhage again. But this hemorrhage is a different kind of hemorrhage. This is either reactionary hemorrhage and secondary hemorrhage. Now, the first complication that I spoke about was primary hemorrhage, which was occurring at the time of surgery. Reactionary hemorrhage is the hemorrhage that occurs within 48 hours of the surgery, and secondary hemorrhage is the hemorrhage which occurs within 5th to 8th post-operative day. Now, the causes of each one of these is very different. Reactionary hemorrhage usually occurs because there is a loss of effect of adrenaline as it washes out of the system, as the BP comes to normal or even increases after anesthesia, and due to repeated paroxysms of cough. Whereas secondary hemorrhage is more due to formation of a granula and infection. And there can also be pressure necrosis of high innominate artery. In all of these cases, we'll treat it with antibiotics and anticoagulants. Last is a lot of crust formation. This can happen because of dry weather and non-humidified air going to the patient. So one of the primary physiological effects that is changing in a tracheostomy patient is the fact that because the air is not able to pass through the nose, filtration and humidification is not happening here. So, the non humidified air is entering the trachea directly. Because it is the dry air which is entering, it leads to the development of crust. We can deal with this by either placing a wet gauze over the stoma, or we can even use a HME machine. I've already spoken about this in my previous class when I was talking about the post operative care. So these are all the intermediate complications. Last of all, let's discuss what are all the late complications that we'll see. Late complications are seen in patients who are on prolonged usage of the tube for weeks to months. So, our first late complication here is laryngeal stenosis, which is narrowing of the larynx. What are the causes behind this? This can happen in cases of high tracheostomy, which leads to perichondritis of the cricoid cartilage, leading to stenosis of the subglottic region, or if there is improper curvature of the tube, or because of chemical irritation by sterilizing agents, if there is some mucosal damage which has occurred during the time of surgery, if there are movements of the tube because of ventilation or deglutition, or if we have not taken proper care of the patient in the post-operative period, if there is a non-deflated cuff or a over-inflated cuff. It is important to remember the ideal cuff pressure here is 15 to 25 mm of water. You should not exceed this. So, a case of laryngeal stenosis will be treated with steroids, prophylactic antibiotics, and eventually surgery. Second late complication here is tracheal stenosis. Now, the causes behind tracheal stenosis can be due to tracheal resection, tracheal infection, if there is repeated incisions, so repeated incisions given on the trachea while performing the surgery, or if there is a scar contracture on the trachea. All of this will lead to narrowing of the trachea. How do we treat this? We'll have to do tracheal dilatation, and if there is an initial ulcer, that can be allowed to heal secondarily or even excised with a primary closure. Next late complication is a difficult decannulation. Now, this is usually commonly seen in infants and children rather than adults. We'll discuss decannulation in our next class when we talk about decannulation and difficult decannulation. What are the causes behind it? When do we do decannulation, etc. Next complication is having a persistent tracheocutaneous fistula. Now, I spoke about this earlier that there is a fistula or a communication that opens between the trachea and the skin. This is usually seen in case of very long-term tracheostomies, which have been going on for months to years. They'll usually come to you with skin irritation and poor phonation. Our treatment would be to excise the tract till the anterior tracheal wall and perform closure in several layers. Last of all, there can end up being a very disfiguring scar or a depressed scar and keloid formation at the incision site. So, this completes everything we need to know about the complications of tracheostomy and how we classify them into immediate, intermediate, and delayed complications. See you in my next class.